Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is October 27, 2025. This video is on a New England Journal of Medicine article titled Early Withdrawal of Aspirin After PCI in Acute Coronary Syndromes, and this is published by the NEOMINDSET trial investigators. DAPT, dual antiplatelet therapy with aspirin and potent P2Y12 inhibitor, is standard for post-PCI in acute coronary syndromes, but increases bleeding risk. The trial tested whether immediate discontinuation of aspirin and monotherapy with prasugrel or Ticagrelor is non-inferior in preventing ischemic events and superior in reducing bleeding. Study design, multi-center, open-label, randomized controlled trial with blinded endpoint adjudication, conducted across 50 sites in Brazil, funded by Brazilian Ministry of Health. Participants, 3,410 patients with acute coronary syndromes undergoing successful PCI. Mean age 59.6 years, 29.3 were women, 29.3% were women, 27.4% were diabetics. Index event, 62.1% were STEMI, 30.5% in NSTEMI, and 7.4% had unstable angina. Follow-up, visits at 1, 6, and 12 months, median time to randomization 2 days post-admission. Intervention groups, monotherapy, P2Y12 inhibitor only, either Ticagrelor or prasugrel, DAPT, aspirin or with P2Y12 inhibitor for 12 months. The primary outcomes were a composite of death, myocardial infarction, stroke, or urgent revascularization, tested for non-inferiority. Major or clinically relevant non-major bleeding, tested for superiority if the first was non-inferior. What did they find? Primary outcome for ischemic event, 7% in the monotherapy group and 5.5% in the DAPT group. Absolute difference was 1.47%. Non-inferiority was not met, p-value 0.11. Primary outcome for bleeding, 2% in the monotherapy group, 4.9% in the DAPT group. Absolute difference minus 2.97%. Formal superiority not tested due to hierarchical design. Secondary findings, stent thrombosis in double digits, 12% in the monotherapy group versus 4% in the DAPT group. Net adverse events, 8.5% in the monotherapy group versus 9.9% in the DAPT group. Serious adverse events, 9.4% in the monotherapy group versus 10.4% in the DAPT group. Limitations, open label design, lower than expected event rates, underpowered for subgroup analysis. Trial population largely low-risk STEMI patients. Key takeaways. Early aspirin withdrawal increases early ischemic risk. Bleeding is lower with monotherapy. DAPT remains the standard for high-risk acute coronary syndromes post-PCI. Clinical pearls. First, DAPT remains gold standard in ACS post-PCI, especially early phase. Second, early P2Y12 monotherapy within 2 days may reduce bleeding but increases ischemic risk. Use of full dose prasugrel or Ticagrelor distinguishes this trial from prior studies. Subacute stent thrombosis is higher with monotherapy and underscores the need for dual inhibition. Patient selection is critical. Avoid early aspirin withdrawal in high ischemic risk events. Eponyms and key terms. I'll let you hit pause and read this at your leisure. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.